Lou?
Are we live, Nigel? We're live now. So welcome to the Adult Social Care and Community Scrutiny Committee. I'll just hand you over to the chair of the committee, Councillor Stephen Hurst.
Good morning, everybody. Wasn't that an exciting 10 minutes? It's nice to see you all looking very healthy and well. So, we're all here. Yeah, we're all here. So we'll kick off with item number 1, apologies for absence. Do we have any apologies, Laura?
So, well, we don't have Sean Parsons. I haven't heard from him, so I don't know if that's technically possible or not, but he's not.
Okay,
he's not
thank you. Next on the agenda is the minutes of the last meeting. Does anybody have any comments about the minutes of the last meeting, or can we proceed to accepting them? Deathly hush. Ian, you're muted. You can't hear me though, can you?
Okay, I'm on now. So I just wanted to comment on the performance report, which is paras 26 onwards. At 26.7, it says members were also informed that the suicide rate per 100,000 population remains below target. I'm just concerned that that might be misinterpreted by the public. You know, suicide rate. You know, we have a target for a suicide rate. Is that a good target or a bad target? I just wondered if next time that might be clarified in a little bit for the public. That's just all.
Is there not an explanation that bigger is better or smaller is better?
Well, if people are just reading the minutes, they'd only see there's a suicide rate target and we're below target. So does that mean that we're good or bad? It's just a little clarification in the wording. We improved. That's all. It's a small point.
Do you have anything to say there, Laura?
Sorry, Stephen?
Do you have anything to say about that situation?
So, did you have your hand raised?
I just wonder whether
Ian hasn't got a hand to raise because it's on his iPhone.
No, Sarah's raising her hand.
That's going to be Sarah.
Sarah,
Stephen.
that's my indicator. So we don't have a target as such. I think Ian's absolutely right to raise this. Clearly, we want levels of suicides to be as low as possible. So I think maybe we just need to amend that. It might be that there was a comparison with a regional average or something. So I think we're always seeking to be less than our comparators, aren't we? But maybe I need to go away and review it, Ian, because I can't see it on my screen at the moment. And so perhaps suggest an amendment.
Okay.
And share via email. I'll take away an action to do that.
Thank you. That's it.
Any other comments, folks? No, thank you. So we accept the minutes with that revision. Is that okay?
Yeah.
Yeah.
All happy? Thank you. We now come to...
We've got declarations of interest next.
Yeah, declarations of interest. Anybody has any declarations to declare other than they've already declared on their annual return? No.
Nobody showing,
Okay.
Stephen?
No one's showing at all. Thank you. And we now come on to Margaret's first part of the meeting, who's going to tell us a report about the support to care homes during COVID-19.
All right, just bear with me.
Which are pages 11 to 18, if you've got the papers there or on the screen.
Okay, Stephen, so this is quite an extensive report, I hope you find, and we've tried to put in to capture the detail so that you can see the range of services that have gone in to support care homes, which was the particular request. When we come on to my second report, there's a bit more of the general stuff in. It ranges obviously from guidance through to practical assistance, PPE training, PPE supply, and financial support. Since this report was written, we've now motioned for the June payment, which is going out this week, so a further 10% that Carol has endorsed as the lead cabinet member. And we have calculated how much it will be for us to continue that through to the end of September. but we have been asked nationally to start thinking now about how we revert to the usual way of working. So we've been funding, for instance, day services that haven't actually been delivering a service simply because we want to keep them viable for the future. But we are now looking at whether we can start opening up those services. And yesterday we published some guidance for the county on the things they should think about when they're opening services, not just for the statutory services, but for the voluntary sector and the private sector. So probably if I just take questions from anybody on anything in that report, I'm happy to give more detail or to explain any particular bits of it, allowing me to jump between screens if it's with a particular reference to one section of it.
We've got Ian, Stephen, that would like to speak. You're unmuted, Ian.
Okay. First of all, I wanted to say I really appreciate this report. I think it's very comprehensive, and I like the way that the care homes have really been enveloped now in terms of being looked after, particularly for the CCG, but also the county council. For example, with clinical leads now for every care home and a weekly contact and so on and so forth. With the money now coming through from the government and we're dispersing it to care providers, Margaret, I just wanted to ask you on that, because I've seen elsewhere that when it comes to the sicknesses in care homes, they've done some analysis on the figures, and they found that where care home staff or agency staff working in care homes weren't being paid sick leave, not surprisingly perhaps, they were going into the care homes because they couldn't afford not to, perhaps. It could be argued. And anyway, the net effect of it was that those care homes had higher rates of infection. So following on from that, I just wondered, now that we're giving more money to the care home providers and through them to their staff or their agency staff, what are we doing to ensure that those staff have proper sick leave provisions so that they don't feel compelled, wrongly, I would say, of course, to go into work because they can't afford not to go into work and therefore running the risk of increasing the rate of infection? Could you say anything on that, Margaret, either here or in your later presentation later on the agenda?
Yeah, it's a tricky one. So in part of the offer to care homes, we asked them to try and pass on some of that money to their frontline staff. Most of the homes have not done that on the basis that they believed that as it was county council money, then it was for county council residents, and they would have to proportion the spend between staff looking after our residents and staff looking after self-funders or residents placed from other local authorities. I have a view on that, which you can guess. But unfortunately, I wasn't able to persuade them that they should. And that even includes the Order of St. John, so they haven't passed it on to their staff. What they have done is to make sure that their statutory sick pay is honoured, which is the normal terms and conditions for staff working in that sector. Very few of the organisations pay full pay for sickness as we do in the statutory world. But we have no evidence that they haven't been able to do that. We've also had quite high numbers of attendances. So the Order of St. John, for instance, which is our biggest provider, swabbed all of their staff very early on in the pandemic, and they're about to do them again at the moment. And we're going for weekly testing soon. And they had 97% of their staff COVID free. So they didn't get the levels of sickness that they were expecting. Now that's maybe not the same in others. So again, there's a home in the Cotswolds that had a high level of sickness, and we were able to try and support them while they stabilised their workforce. But generally speaking, it's been relatively sound. I don't know, Sarah, if you want to comment from the side of it, from infection control, that you see.
I think Margaret's outlined the issues really well, actually. I think we do see a range of approaches throughout our care homes that they're all on a spectrum in terms of size and whether they're part of big nationals or small homes. So I think the work that Margaret's outlined in her report with the integrated brokerage team, I mean, Ian, you commented on the new work in terms of the designated clinical lead. That's quite an old piece of practice, really. We've had it for quite some time in Gloucestershire. So I work with this is Margaret's bit of the business rather than mine, but my understanding is that we have for quite some time actively supported our care homes, and certainly during COVID that the daily calls have stood up. But if I want to know anything about a care home, I go to our integrated brokerage team because they're in daily contact, and they are there to support the care homes. And of course, care homes are businesses. There's a limit to what we can get them to do. We can offer advice and support and free training, but we can't necessarily force them to do things. I think we've done a lot of this through the good relationships that integrated brokerage have built up.
Yeah. I suppose I'd add another example. So one home had a number of COVID positive residents early on again in the pandemic, and the staff there agreed, well, they offered, we didn't ask them to do it, but they offered to go and live in the care home for 7 days at a time. So they did, they were there 24 hours a day, 7 days a week, and then the other shift came in for the following week. And they did that until all of the residents had now tested negatively, and they tested the staff regularly. So they've been tremendous in the way they've responded, to be fair to them. They've had a very bad press, which I think is unjustified.
Let's just get Ian back. Hang on, Ian.
Yeah, thank you for that comprehensive reply. I think later on I may come on to the business of, later on in the agenda, of contracts and whether we can influence the providers to ensure that they're treating the staff or the agency staff that they employ properly. But I'll leave it later on in the agenda. Thank you.
Okay. We've now got Jeremy.
Thank you. Can you hear me okay?
Yeah, we can hear you, Jeremy. Yeah.
Yeah. I'll just declare a personal interest in that my partner works in a care home, but you know, what's happened in our care homes, not only in Gloucestershire but nationally, obviously is a tragedy. I think that 79 of our care homes were infected with COVID-19 infections, and that's well over 200 of our elderly residents who were in there, lovely old people that were probably put there because families thought they would be safe, subsequently died from an infection with COVID-19. And I think one of the problems at the beginning, of course, there was no proper lockdown of our care homes, that we were still seeing transfers from hospital into our care homes where there was not COVID-19 test done. No, they tested those who had the disease and those who were showing symptoms, but not those that didn't show anything. And it could well have been that those people were infected. But also the issue of agency staff moving between care homes, of the lack of proper training and PPE for the staff within the care homes, and also the fact that we weren't testing our staff in care homes or the residents. A whole load of those issues are what caused the outbreak of deaths in our care homes. It was about 47% of all deaths in Gloucestershire. That's substantial, and we ought to be sure that we protected the care homes in the future. So I just wonder whether both Sarah Scott and Margaret Wilcox can tell us and reassure this committee that if we do get a second spike, that we won't get a second spike in our care homes, that we've taken the measures that will protect those care homes, and that we've got a plan in place. I don't think we had a plan in place. You know, I think, you know, our plans for a pandemic didn't cover what happened here. And I think we need to make sure that we have a plan in place so that if we do have infections in our care homes, it's maybe half a dozen, not 79 or 80 of them. Thank you, Chair. I appreciate an answer from the two officers.
So, Margaret, you're on mute. Do you want to start? And I can do testing and the pandemic plan after.
Okay. So what we do know, Jeremy, is that of those in that early stage, there has always been a plan for care homes. We followed the national guidance from the very beginning. And so we went into lockdown when the national guidance told us to do so. And in fact, some of the homes went into lockdown earlier because they took a corporate decision themselves that that's how they wanted to do so. If you take the Lillian Faithful group, for instance, they closed their services almost immediately to the public, which didn't go down well with the relatives, but it was the right thing to do in the meantime. The number of people who died in those early weeks is less than 10. So we know that COVID-related deaths from transfers from hospital was actually very small in Gloucestershire and has continued to be very small. And the hospital has behaved extremely responsibly, introducing 14-day quarantines very early on, probably before many other places. And the other issue is that obviously people are in care homes because they have high levels of need, and the average length of time for somebody to live in a care home is 18 to 24 months. So sadly, most of the people who have died probably would have been dying in
Margaret,
Oh, somebody muted me, but it wasn't me. So it is difficult, and I think, to be fair to the homes, they have been very compliant on the whole with PPE practice, and they've had to learn how to barrier nurse. Most of those homes, with the exception of the nursing homes, were not familiar with this type of approach. There's never been a shortage of PPE in the county. We've been awash with equipment for people, and we've been extremely generous with it, and we've not charged anybody, which other counties have or other councils have. So I think we need to be mindful of the fact that our care homes have always been well supported in this county. We've had a very long-standing relationship with the Care Providers Association, and that's paid off in this pandemic. There are one or two homes that are not as collaborative as we would like them to be, but we are aware of those homes, and we do everything we can to support them and to encourage them to be compliant with the guidance. And obviously the guidance has changed along the way, and we've helped them to respond to that accordingly. Sarah, do you want to talk a bit about the infection itself?
A few points there, Jeremy, didn't you? There's something around our pandemic plan, and was it right for care homes? And I think there's also probably something to say about testing. So we didn't have a plan for COVID because COVID didn't exist until December last year. So we've got a plan for flu, for if we had the flu pandemic. And in the beginning, the national advice was to use that because there were some similarities in it. It was a respiratory virus, but we quickly learned it responds very different to flu viruses. So I think Margaret's outlined the approach for care homes. So to be an answer to your question, no, we didn't have a pandemic plan, because we didn't know anything about the virus till December. I think the other bit to highlight really is about the testing. So testing for care home residents and staff was rolled out in May, and by I think the 6th of June, the national ambition was that every care home for the over 65s and people with dementia would be offered testing for staff and residents, regardless whether you had any symptoms. And there was a 100% offer for all of our care homes in those categories. And again, the integrated brokerage team did a great job of contacting those that hadn't registered, trying to convince and control those that hadn't had the testing to have it. We didn't get 100% of our homes tested, but certainly 100% of them were offered. And then after that, the government asked SAGE, the Scientific Advisory Group for Emergencies, to consider whether there should be more frequent testing for care home residents and staff. And this really, there was quite a strong call from some quarters for this to be done weekly. And I don't know if any of you have had a COVID swab, but if you're perhaps suffering from dementia or if you're elderly, it can be quite intrusive. That swab has to go quite far down your throat and then eye-wateringly high up your nose. And so there was a lot of discussion around, is it fair, is it ethical to subject people to this every week? It was discussed at the Southwest Health and Care Ethics Board. And the feedback from SAGE has been, and Margaret and I had a letter on Friday about the new care home testing strategy, is that what they're saying now is for homes without an outbreak, staff will be tested every week, and that includes bank staff, agency staff, social workers who are visiting members of staff, allied health professionals. and residents every 28 days. We'll be testing everyone initially focusing on care homes for the over 65s and those with dementia. That started yesterday with people being able to register for those tests. If there's an outbreak, then we still test people in the home if there's an outbreak. We always have, and this is led by PHE. But there's a bit more of a standardised testing schedule. So you'll test people with the symptoms, and then what they do is they repeat the tests between day 4 and day 7 after the first person had symptoms on those that were negative to see whether they perhaps we just had a very low viral load, to try and be really rigorous in catching people that have got the virus. And then they'll repeat the testing at 28 days after the first symptoms were identified to make sure we're trying to capture all those that have got the disease. So it's much more rigorous. It's based on evidence. It's based on the advice of SAGE. And I think I do feel as if, I don't know if Margaret agrees, that perhaps we've been heard. I know ADAS were quite vocal in is it fair, is it right that we subject these people in care homes to weekly tests? Because there's also a risk of potentially damaging nasal passages and all sorts of things. So we do need to be really careful we don't cause more harm. So that, I think, it feels like we've reached a balance. So that new testing strategy has been implemented, as I said, from yesterday, with the portal being open. And I believe the first test will be going out from next Monday. And what's also really encouraging is that, of course, we talked about care homes. We have a care sector with extra care supported housing and dom care as well. And this new testing strategy will also consider the need for testing in extra care housing developments. And Margaret and I are due to receive more information on that, and also the approach for dom care as well. So it's really pleasing that we've got a more comprehensive approach to our care sector. Happy to take any questions.
Thanks for that. Obviously, quite a lot of work has been done since the beginning of the outbreak, and I hope that our pandemic plan has been updated and amended to deal with COVID-19, because we've now had the virus. And I also think for the future, we need to look at the plan for a pandemic for another new virus and see whether we've got procedures in place that will protect people in our care homes in particular. The Prime Minister suggested that some care homes weren't following procedures. I don't know whether we've any evidence of that happening in Gloucestershire, but I believe the problems we've faced were down to a multiple of issues, from lack of testing, the inability to test people right at the beginning, plus the fact that using agency staff and everything else. But I just wonder whether you feel that our care homes have got something to learn as well as the county council in the way we handle a future pandemic or a second spike of this COVID-19 virus.
Well, I think certainly agency staff has been an issue in Gloucestershire, but not for those reasons. The real problem with agency staff is that most agency staff have refused to go into a COVID positive home. So actually long-standing relationships between care homes and particular agencies have been fractured because the agencies have been unreliable, which is unfortunate, but that's their choice, that their agency workers, they can choose where they want to work. But that's one of the reasons why some homes have actually changed the way they work and have consolidated their staffing in a new way to make it more resilient. Some agency staff had left homes high and dry, they just didn't turn up. And we've had a number of sort of emergency conversations about how we cope with those. In respect of a second spike, then certainly doing, oh, sorry. Who's that name? In respect of a second spike, certainly doing, so we're preparing for that, and most homes have been, as I said, very compliant. There are a couple of homes that have been reported generally by the ambulance service for not using PPE appropriately, and we've intervened straight away when that's occurred. We've done some retraining with some homes who don't believe that they need to use PPE because their residents have tested negatively. Sarah knows my view about testing. I am not a huge fan of testing because I think that all homes and all of us should assume that we're all positive and behave appropriately, both in terms of PPE and social distancing and hand washing. Too many negative tests can make a home overconfident, and then they think that they don't have to comply with the rules. I'd rather that we assume that all of the homes have got positive staff and positive patients, positive residents. It's a much safer way to behave. I don't know whether Sarah would agree with me or not, but that's been my long-held position, and
I do agree. I do agree, and that's one of the risks of testing, is that you give people a false sense of security, that and they then take their eye off the ball in terms of the hand washing, the social distancing, and the PPE. It's a very difficult balance to strike. So we are where we are. We've got a national testing strategy now, and we'll do our best to implement that, because that's our job. But that we do need to carry on with the comms. And you mentioned the outbreak pandemic. In my report, Jeremy, there's quite a detailed briefing on the outbreak management plan, which is exactly what it says in the tin. It's about our plan for managing outbreaks, but also it has a huge preventative element in it about how we prevent outbreaks. So comms and care homes are one of the high-risk environments. It's really key that we get our communications right to get the message across that it's not just about you've had a test on a Monday, you're okay, go about your business as normal, because you won't be in a normal situation for a very long time. So that's why it's a complicated situation, I think.
Thank you, Chair. I've finished.
Okay, thank you. Nigel? Jeremy? No, we're all happy.
No one else indicating to speak, Stephen. Apologies, I've had to swap devices. I don't know if anyone else is suffering with connection issues. I know Wayne's had 1 or 2 issues, but I've had to swap devices. So if you are having problems, it may be worth logging out and logging back in. No one else looking to speak.
I would like to speak.
Oh, Brian.
Yeah,
you got your
I thought
hand
I had
up.
my hand up, but it's not.
Sorry,
now,
Brian,
so.
didn't spot that.
Go on, Brian.
Okay, couple of questions really. One is I suppose a basic question about these tests. Is it a test that you're free to take or not take? So are people in care homes or staff or anybody else able to refuse if they choose to, or not?
They absolutely are free to refuse them. They are.
Okay, because in many cases the test is a main benefit to the community rather than to the individual. So I just thought that if they're an unpleasant test, and certainly if you're elderly and may have dementia or something, then we shouldn't really be taking away their right to determine what happens to them.
I mean, I've had a COVID swab, and my children have had it. I mean, it's mildly unpleasant. I've had far worse medical procedures done than a nasal swab for COVID. But I think it's the fact that, I might have to have it once, maybe twice during this pandemic. I think people are, of course, at liberty to refuse testing. I think the government's approach has seemed to sort of suggest that it's our civic duty to get tested, to self-isolate, the social distancing, and that's how we've tried to go by sort of consensus, haven't we, during this, and using lockdown as a last resort. So yes, they can refuse. I think that it's helpful for the homes to understand who is COVID positive and who is not, because there are some different precautions that are taken. But the staff and residents are absolutely at liberty to refuse the test.
Okay, thanks. My second question is probably for Margaret, I guess, and that is actually if care homes residents stay for around 18 months to 2 years, and the vast majority of them are self-funded and therefore are there by choice or discussion with family, not necessarily by social care, then they do need to replace all of their residents sort of every couple of years on average. And I just wondered what the impact of this pandemic and the public perception of it in care homes has had on people going into care homes in recent months. Are we seeing, it strikes me that the two things could be happening. One is that even if the care homes come out of this quite well, they might actually have a big struggle to manage their finances if the number of people choosing to go into care homes drops even temporarily. And the other thing is, if people are staying into the community for care with symptoms that may be better off in the care home environment, is that putting a strain on the adult care in the community services? I just wondered if there's any information coming forward about how people are making those sorts of choices.
Yeah, so in Gloucestershire, about 50% of the people in care homes are self-funders. The other 50% are funded by the state. That would be different. So if you looked at somewhere like Leeds, 90% of the people in care homes there are funded by the council, only 10% of self-funders. South East, 60-65% self-funders. So it varies across the country. And as well as demand, that means that there's a variety of providers as well. So the areas with big numbers of self-funders tend to attract many of the big branded organisations, whereas local authority funded areas tend to have many more smaller family-run businesses or small networked businesses, charitable ones. We've seen, you're quite right, I mean, the number of voids in care homes has gone up substantially because a number of care homes are still not admitting new residents, although several are now, providing they've been swabbed first and then go into 14 days isolation if necessary. But the demand for care homes has gone down, and that's not just locally, that's nationally. People have been frightened by the number of deaths in care homes and also by the whole concept that the care home industry has largely been built about it being an alternative to your home. So it's been friendly and warm and cuddly, I suppose is the word. And actually they've been asked not to do any of those things in this current climate, that it's become far more clinical and much more hospital-like. And that's not the business that some of those companies went into. It certainly isn't where people thought that they wanted to live, in a hospital environment. So the demand has gone down by families, and the demand has gone down by the self-funding market. And we will see, without doubt, some care homes diversify into other businesses and some care homes close. Some will decide it's not for them, that this pandemic has shown them that it isn't what they set out to be. Because really, most care homes are run on a model of hospitality, sort of like a hotel, but with care, as opposed to, as I said, clinical environment. The homes that have done the most amazing job, I think, that we have to give credit to, are the homes which have disabled adults in, so particularly learning disabled adults. We've had low numbers of COVID infections in those homes, and obviously they tend to be more stable because they have long-term residencies, not predominantly elderly, frail people towards the end of their life. And so I think we are going to see some significant changes. In respect of domiciliary care and other social care services that we either provide or commission, again, there's been a drop in demand for domiciliary care because people don't want other people in their homes. And we'll see that even out and start to pick up. The number of referrals to adult social care had dropped, but is now back to its normal levels, if not a little bit higher than usual. So we've seen that performance pick up, and we're seeing obviously more traffic through the hospital and therefore more discharges. But the whole environment has definitely changed as part of this.
Thank you for the update. Thank you.
Do we have any more questions, members?
Yeah, Steve Robinson.
Thank you very much. Thank you, Margaret, for your report. Just asking, on page 14, the update, you mentioned about the antibody testing in care homes and that it was on hold. Do you think that would help the care workers in those homes to know that they were clear of it? I know we don't really know whether people can catch it a second time, am I right in thinking that? But would it help if the care workers were offered that test?
Do you want me to take that one, Margaret? You're on mute.
Yes, please, Sarah.
Okay. So colleagues will remember that the antigen test whether you've got it now, which was the testing strategy I talked about earlier on. An antibody test whether you've had it and you've developed some antibodies to it. What we can assume with a lot of other diseases is if you have antibodies, you have a degree of immunity. And I think that's just not very clear at the moment to how long that immunity may last. There's a lot of antibody testing going on initially in the NHS to understand how it's moved through our NHS staff. Through our collaboration with Gloucester Hospitals Trust, we've arranged for some of our frontline social workers, I think around 400, Margaret, isn't it, to have the antibody test going forward, because they had some of the tests left after they'd done their own staff. So going forward, I think there is an ambition to try and roll this out, but we need to be mindful about how useful it is, the issue of perhaps of giving false assurance to people that they are safe, they've got some antibodies, but we don't know whether they can catch it again. We don't know how long the antibodies protect people for. So I think in a way that part of the national testing strategy is more to learn more around COVID and how it moves through populations of people, rather than to give the individual a guarantee. As you would, for example, if you have 2 doses of MMR, you can safely be assured that you're protected against measles, mumps and rubella for life. That's what the 2 doses is designed to do. We can't say that about COVID at the moment. So I think they're more for research purposes, understanding how it moves through populations than for individual benefit at the moment.
Thank you.
Thank you. Are you happy with that, Steve?
What Margaret said about, earlier on that people should still, do the distance and everything else, and she's quite right. Yeah, thank you.
Okay, thank you.
No one else put their hand up on the list that I'm looking at?
No.
So can we then move on to Wayne in safety? I think we can. Wayne, are you amongst us?
Wayne,
I am.
you're okay, Wayne, all right? Okay.
Yeah, so if you don't mind, I know it's not good etiquette, but I'll leave the video off just to try and keep the internet connection stable as long as you can hear me.
Pajamas on, haven't you?
I have. I can give you a quick flash of video to prove I haven't, Councillor Hirsch, but then you might spot the chilled lager that I'm drinking whilst. No, I'm joking.
He's got breathing apparatus on, Stephen. That's right. Right. Okay, that's a good idea, Wayne. Actually, because it means that you're not going to be taking up bandwidth, and you should be okay. All right.
Yeah. Okay. So thank you. If you can hear me. So just to go through the impact of COVID on GFRS, and some of the headline information is contained within the report, but very limited, because really it's been quite a moving feast. And I suppose you can summarise the contribution that GFRS, as part of the County Council, has made to the COVID response has been predominantly around logistics and providing personnel and training to carry out certain tasks in support of a variety of other agencies, which I'll come on to. But I suppose some of the important headlines at the start are around the fact that throughout the pandemic, we've maintained 96% availability of all the resources, so all the frontline fire appliances. That's slightly higher than normal, and the reasons for that are obviously we've got a high proportion of the workforce are on call, and many of those will have been furloughed or unfortunately maybe even lost their primary employment and have therefore made themselves more available to provide cover for the fire and rescue service. So availability throughout has been very good. Many of those people have also then made themselves available to carry out additional tasks, which I'll come on to. Even though our availability increased into and throughout May predominantly, we saw a significant reduction in the number of incidents we responded to in comparison to the same period of the previous year. So, for example, the number of treble 9 calls coming into the fire control room were down 22%. Obviously, the demand was much lower from the public, and I think we saw all emergency services deal with the same reduction in demand. The number of incidents we attended in total actually reduced by over 17% at times. including the number of responses to things like cardiac care and medical emergency, which we normally respond to in partnership with or on behalf of South West Ambulance Service. They were down by over a quarter. And again, that was because of not only the lack of or the reduced requirement for acute medical care, but also we saw it in A&E departments as well, where that the attendance was much reduced because people were staying at home and avoiding that kind of treatment and that kind of interaction, and hopefully suffering accidents or serious accidents less. In terms of the more run-of-the-mill business that we deal with, i.e. fires and road traffic collisions, 13% reduction in fires, 71% reduction in road traffic collisions at the height of lockdown, particularly. But again, we have seen some quite serious road traffic collisions, because you will have seen in the media, no doubt, and through road safety, that there's been some speeding campaigns. So where there have been road traffic collisions, the severity has been quite bad in terms of the number of people killed or seriously injured because of the speeds and the quietness of the road. So that's a snapshot of kind of incident demand and how we were affected. What I can say now, as lockdown has been through that phased release, those incident levels have all returned back to normal. So we're within plus or minus 5% of normal demand that we would expect to see at the same period in previous years. So we saw a significant reduction that's then gone up. In terms of other impacts on the business we conduct, that goes hand in hand with some of that incident demand. Really, we saw a reduction in the number of safe and well visits that we undertake, and that is a concern. Obviously, that was imposed by us and following medical guidance and PHE guidance around visiting people's homes. We did, throughout the pandemic, we continued to undertake the very high risk safe and well visits with the required PPE. We also changed the way that we undertake safe and well visits. So, for example, where people were able, we'd get them to use a WhatsApp video call, and we'd carry out a video-based, very much like this, safe and well visits with people, but in the lower risk categories. The impact that's had on our safe and well work, though, is that you might recall from our previous HMI CFRS visit that we did have a safe and well backlog because we got some confusion in the way we stored data. We'd almost eradicated that safe and well backlog, but unfortunately, because of the reduced activity around safe and well, i.e. targeting the very high risk only, that backlog has now risen back up to in the region of 500 outstanding safe and well visits. We took a paper to our strategic leadership team last week, and we've agreed to reprioritise some of the budgets, and we will be using fixed term contracts to bring in 3 additional community safety advisors to fundamentally change the way that we carry out and the way that we target safe and well visits. So I'm hopeful that backlog of 500 will be back down and probably eradicated within a very short period of time. Now we are back into delivering safe and well visits as we would have been before. That brings us on to other reductions in activity. So fire safety audits, you'll be aware that again, our business fire safety and our fire protection work was a cause of concern identified by the inspectorate. We've carried out a significant amount of work to improve both the way we target our business fire safety work and the amount of resource and the skill and competence that we've got to do that. That was seeing some significant progress, and again we had a re-inspection by HMI CFRS who confirmed that we were moving in the right direction at an impressively rapid pace. Unfortunately, we've had to move to what we've called the desktop audit process. So clearly we haven't been able to visit business premises during COVID unless there's been a significant and serious concern in a business that has still been operating. where visits have been undertaken, but they have been very, very few and far between. So whilst we've been carrying out in the region of about 300 desktop audits, we still need to physically visit some of these premises. So we'll be ramping up that work in earnest again now that we can. But again, what that means is we've got a target audit process over the next 2 years of how many of the high-risk premises we want to visit. And we're re-evaluating whether we can put additional capacity into that or whether we'll have to slip the 2 years, and what was hopefully going to take us 2 years might now take us 2.5 years. But again, that will be reported and monitored back through this scrutiny group, and also HMI CFRS will show a keen interest in that when they come back and re-inspect us. There's been some impact on firefighter operational training. Fortunately, not the risk critical training. Some courses have been delayed. Our regional training centre down at Severn Park was closed for a period of time, so it could no longer deliver some of the core training that we commissioned from that site. That did open again in the first week of July, so that's back up to delivering normal business. We did manage to continue to run our trainee firefighter courses. We introduced some social distancing measures to do that. And we also introduced some additional controls where training is undertaken and people couldn't maintain a 2-meter distance. So, for example, putting ladders up, or training in road traffic collision practices, that kind of thing. And I'm glad to say that where we have had staff tested and where we've maintained that, we've not had any cases of C19 within the workforce. We've not seen spikes as a result of that training, so it would appear that the control measures we put in place have worked adequately. And then I suppose it brings me on to the additional areas of work that we've undertaken. As per some of the comments that Margaret made about adult social care, I think fire and rescue has really demonstrated, probably nationally, but it's important to mention that we had cause to write to the chair of the Local Government Association Fire Service Management Committee that Councillor Norman sits on. He asked for a bit of a round robin from the sector to see what services were doing. So we quickly pulled a letter together to him that we felt it appropriate to forward on to the Fire Minister for his attention, in addition to a response that he'd asked for. And the feedback that we've had from that, from other members of the Fire Service Management Committee, i.e. chairs of authorities around the country, is really that they are quite blown away and staggered by the volume of work and the breadth of work that Fire and Rescue has undertaken in Gloucestershire. And there's a bit of relevant context with that, which is that the National Fire Chiefs Council has been in twice weekly negotiations with both the Home Office and the LGA, who are obviously the employers, so that the National Joint Council, and the Fire Brigades Union, who can be difficult in some areas, but I'm glad to say industrial relations here locally are very positive. But they've been in twice weekly negotiations on what they've called a tripartite agreement for the kind of work that can and should be undertaken by fire and rescue services, which started off with 4 or 5 specific items, i.e. driving ambulances, delivering food parcels, that kind of stuff, has since grown. It's currently on its 10th version, or its 10th iteration. And I have to say that some of the work that we've undertaken in Gloucestershire goes far beyond the work that's been agreed on in that tripartite agreement, which, while it's a risk to local industrial relations, is also a massively positive story about the willingness of the workforce that we've got here to step in and support other departments within the county council, particularly public health, adult social care, children's services, wherever we touch the vulnerable in our communities. Firefighters and our support staff have absolutely stepped up and stepped in and delivered critical frontline services. Now, some of that is quite low level. it's logistics, it's delivery, but again, it's critical. And I think it demonstrates for me the value of having really close relations with those other departments within the county council, whereby, Sarah or Margaret can literally ask me in a phone call or a video conference or fire me an email, and the same day something is happening. Whereas, my experience of other services has been that can take weeks or months of negotiation, service level agreements, legal involvement, and all kinds of stuff. So I think that really should be commended. The type of work that's happened, it's really positive. So some example is just working around the PPE. So I think fire and rescue staff have been instrumental in storing, distributing, cataloguing PPE right across the local resilience forum. So that's into care homes, into other care settings, into hospitals at times. Delivery of the food parcels to the vulnerable, operating right across the local resilience forum command structure. We've had officers embedded at various levels, supporting and helping other partners, the LRF, the military planners that have been in. A big piece of work that's already debriefed, and again, it's very sensitive, but it's been delivered phenomenally well with a great degree of dignity, is body recovery and the management of the temporary house of rest. We've had a significant number of staff involved in both the development, the setup, and then the delivery of that service, which I think has been done phenomenally well by a range of partners who've been involved, but again, fire have been heavily involved in that. It wasn't used, but within a very short period of time, we explored and established a process for a drive-through facility at one of the fire stations, a drive-through testing facility. That wasn't used, but it was ready to go where it required. We've then trained other blue light organisations in the use of PPE initially. So that was what you might have heard referred to as P3 respirators. So for frontline staff, ambulance and police staff who might have needed to use them, you have to go through an appropriate testing facility to make sure that PPE is working for you because of the level of protection it provides. And you have to be trained and have special equipment to actually be able to carry out that test, which is something we have in-house. So we offered that out to other services, and the few individuals we've got trained have been extremely busy doing that. We have then supported the testing facility as well with both the military up at Oxtalls and then Hempstall. We've also then carried out the delivery and the collection of swab tests to care homes and other members of staff to try and accelerate the number of tests that we could get delivered across the care sector. We've then stepped up and started to deliver training to some of the care homes and the domiciliary care workers in the use of PPE and infection prevention control. And that continues, and that again is in support of adult social care and public health. So, as you can see, the work's phenomenal. And the final bit I'd draw attention to, I think, is the support to South West Ambulance Service, which has been key. So we've every 12 hours we've been supplying 2 blue light trained drivers initially, and now that goes on to medically trained firefighters to actually crew ambulances. So they've been carrying out that work now for several weeks, and that was a piece of work that was nationally sensitive, took some negotiation, but effectively we turned that around in Gloucestershire because we work so closely with SWAST anyway. We turned that work round within a week to 10 days, and we're ready to go. We then had to wait for some of the national work and the Association of Ambulance Chief Executives to do what they needed to do, and then we immediately switched that work on, and that continues to date, and we've now extended it to the end of August to support the ambulance service with the preparation for winter pressures. So effectively we have SWAST have an additional ambulance available in Gloucestershire every day for 24 hours a day as a result of firefighters crewing those ambulances with paramedics, which again is a hugely positive piece of work. Obviously, we are involved in the recovery work with GCC. We've managed to maintain the majority of staff working from home. In terms of cost to fire and rescue, we believe that the response to COVID has probably cost in the region of £500,000, which is generally associated with pay. But if you think back to the start of this briefing and the reduction in demand, that pay is probably more likely to be offset or negligible once we take out the savings from normal business, fuel bills, you know, the normal overheads that we've got to run the service. However, the Home Office do have a grant process in place that specifically around fire and rescue services, and we do meet the threshold. So we are in the process with finance of submitting a request for reimbursement for COVID response funding from the Home Office grant back into the County Council. And lastly, what we've done in terms of business continuity is we had what we call a degradation plan anyway of how to manage pressures on the service. As a result of COVID, obviously HMI CFRS work ceased, so we pulled back 3 of our staff who were seconded to HMI CFRS. One of those works in the data team at HMI, and he's done with others a phenomenal job on a complete review of what we call our degradation plan. So I'm really pleased with the quality of that now and the information it provides going forward into our integrated risk management plan and the data that we do for that. And I think we've got an extremely robust degradation plan now. So any other future pressures, i.e. second wave or spate conditions around flooding or major incidents, or even if we need to support other services in the country in response to things like wildfire through summer, we have a very, very clear plan in which to reduce the amount of fire cover in Gloucestershire to respond to incidents like that, and very clearly understand the impacts on the risk levels and the cover available in Gloucestershire when we do it. So again, that's a positive that's spun out for us in how it's made us look at the way we deliver the service.
Thank you, Wayne. Does anyone have any questions of Wayne? Andrew.
Okay. Yes. Okay. Boy, there's so much to take in there, Wayne. It's hard to know where to begin, but I just want to concentrate on issues that I raised before, particularly the work with the ambulance service. The points that you were telling us about the ability, not the ability, but the way you've been working much more closely with SWAS and providing drivers, trained drivers, is absolutely really good. And I'm pleased that that's an example to other forces in the country. And it'd be really good if you could thank your teams, not just for that work, but for all the work that they've been doing during these terrible, terrible weeks and months of lockdown and COVID. I'm sure a lot of the work that they've been doing weren't the sort of reasons that they joined the fire service rescue, anticipating they would be involved with. So it sounds a bit trite, but I think it's really important that they understand that as elected members, we really appreciate their work and their extra miles that they go to. And in particular, the cooperation that they're providing to the local ambulance service. That really is excellent, excellent news. And as I've said, it's something that I've always taken a particular interest in. I was surprised, Wayne, to hear you say that the number of requests that you'd had from SWAS for help had reduced by 25%. And I guess that's in line with the reduction of calls that people make anyway to the ambulance service itself during lockdown, during this terrible pandemic. And I think we've all read in the press that people are reluctant right now, for obviously understandable reasons, to go to their local hospitals for treatment. But in some cases, they're not going for pretty serious reasons, or serious illnesses or conditions, including sadly cardiac issues and cancer issues. So my question there is the reduction, Wayne, in the number of calls that you have from SWAS reflected in the number of calls that SWAS themselves have taken? So there's a lot there. One is just to express my appreciation, all of our appreciation, for the work you're doing with the ambulance service, particularly on the extra driver provision you're giving them. And is the reduction in calls that you're getting from them, Wayne, in line broadly with the reduction of number of calls they're getting anyway across the service? There's a lot there. But there was so much in your report. I'm sure all of us could comment on virtually every aspect of your report. It was such an uplifting and encouraging and positive report during these tough times. Thank you, Chairman.
Thank you, Andrew. Anyone else with a question of Wayne?
Just say to Andrew to lower his hand. Is that all right, Andrew? Sorry.
Yeah, sure. And also, can somebody answer the question?
Would you like me to come back, Chair?
Yes, please, Wayne. Sorry, Andrew.
Thank you. So, well, firstly, thank you very much for the warm comments, and I'll certainly pass them on because I know it does help staff when they understand and know that you're all briefed and supportive of what's going on. They do appreciate it. In terms of ambulance demand, so there were two issues. Bearing in mind we're now back to normal levels of response. So those figures, that 25% plus reduction, was at the height of lockdown and the COVID response. And there were fewer emergency incidents, I believe, that the ambulance service were going to in general. But there are two reasons why we saw that initial reduction. One was, as for all organisations, the ambulance service and the Association of Ambulance Chief Executives nationally had to carry out some pretty rapid risk assessments about the way they did their business in terms of PPE and the risk they exposed their staff to. So they actually stopped all co-responding immediately. So at the very early days of lockdown, we literally had an email at 10 p.m. one evening, and SWAST stopped mobilising any fire rescue service staff to any medical emergency. And that situation lasted for just under 2 weeks before they actually turned on any response. They would then only reinstate co-responding services, which we are classed as a fire and rescue service, where I could, or the head of that service could provide a letter confirming that we had adequate PPE and appropriately trained staff to respond to a reduced incident type. So they then restricted the type of incidents we go to. Gradually, that's been further released. So some of that 25+% was because the ambulance service reduced their use of partners as one of their risk control measures. And the remainder of that 25% is because the public were dialing 999 less. If you think about the kinds of things that injure people or require acute 999 medical response, there was much reduced traffic on the roads, people weren't going out. So effectively the demand was down to those that might have cardiac arrest at home or that kind of emergency. So there's a general reduction. And obviously that's now increased back to normal levels as society's gone back to its normal movement.
Are you happy with that, Andrew?
Yeah, it was one of the best reports I've ever heard as a member of the County Council. There was so much in there, Wayne, and really encouraging in a time when virtually all of the news is bad news. Thank you.
Well, we've had 3 good reports from our officers, haven't we? And I am personally in awe of all the work they have done over and above the normal run of their duties and work. So thank you all very much. Thank your teams, Margaret, Sarah and Wayne, for exemplary service in this past, 4 months now, and more months to come. Thank you. So where are we now? Do you want a 10-minute break? Or are you happy to go on?
I think people are happy to carry on. So
yeah, keep going.
Keep going. Now coming on. We will carry on for another half an hour, and we'll start with Margaret's report. Margaret.
Thank you, Stephen. Okay, so and it's another long report. One of the things that's thrown up in COVID is usually when I call for information to go in my report, I'm struggling to get more than 5 lines out of people. But because people have spent so much time in front of a screen, I had something like 25 pages this time, and I've had to whittle it down, bless them. They're so enthusiastic about wanting to tell you about what they're doing. So hopefully this report gives you a picture, just like Wayne's described, of the range of things that have been going on, and people have been doing exemplary things. A couple of ones to sort of pull out. One is the use of tech. So what we hoped with COVID was that it would escalate the use of technology and digitalisation. And whilst to some extent it has, it's also revealed how poor the amount of the quality of what's available is yet accessible for us. So, you know, I'm sure as elected members, you'll have been inundated with emails from people telling you that they've got a digital solution to every single problem that we've got. But actually, when we've followed most of them up, there isn't a solution at all. So I think what we're hoping that will come out of this is a more expedient way of dealing with alternatives for people so that they can live their lives to the full, but maybe not rely on people quite as much as they currently do. Just to give you a snapshot of how the staff have coped, then I think we've been amazed at how responsive people have been, and have been moved to working 7 days a week, 12-hour shifts without any refusal or reticence. I think some of our staff now are getting a bit tired of being on their own and working from home, and they're looking forward to seeing each other again, but within the circumstances that we can allow. As you know, there'll only be about 20% capacity in Shire Hall compared to what we had before. So we're going to have to think about how we get back to whatever the new normal will be. But they have a weekly, the operational staff have a weekly newsletter that's coordinated by Dawn and her team. And that's been a joy to read, because people have tried to find different ways of having cake competitions or celebrating people's birthdays and all of those sorts of things, to be able to keep that spirit and morale going at a time when actually some of the cases that they're dealing with, the people that they're dealing with, their families, are more tragic than usual. And I think lastly, I would just comment on the hospital social work team in particular, because they've had to work in exceptionally difficult circumstances, and they've been tremendous. We've probably had the best flow through the hospital that we've seen, certainly in my career, and certainly in my 10 years in Gloucestershire. And the working relationships there has been terrific, and we've had lots of compliments. And you'll know that Charles and Camilla came to visit, and our hospital social work team was one of the people that they met on that occasion. So that was a joy. And he was beside himself with excitement, bless him. Got his best suit out, which none of us had ever seen before, so that was quite interesting. I think just to try and show you that even where, for instance, in day services, we haven't been able to have the units open, although we are getting round to that in the next few weeks. We've had staff going out and visiting people in their own homes, doing medicine runs for them, collecting food, and sitting to look after somebody so that their family can have a bit of respite and go out and do whatever it is that they would like to do. So we've tried to adjust. What we're finding in the early conversations about going back to having services delivered in the future is that a number of people have decided that they don't want to go back to the services that they had before. They want to do something different now, and that's been quite interesting. And in some areas, it's quite significant numbers. So happy to take questions on any part of the report or anything else that anybody would like to ask.
Hands up for question.
Just looking down the list now, Stephen. See if any hands are going up. Yeah, Ian. Let me just unmute you, Ian. Hang on, bear with me. Oh, struggling to unmute Ian. You're live, Ian. Go on.
Yeah, I just want to add my congratulations to the work that you've been doing amongst your staff, Margaret, and also the fire and rescue service, and also public health. I mean, it's just been an astounding collective performance, and I love the way that people have been reaching across artificial divides between organisations to help each other and support each other, and how the technology has emerged in the way of an opportunity that's emerged out of a crisis, and how you've really grasped that opportunity, Margaret, you and your staff, to have a look at how technological solutions may help people in our county. So again, well done to everyone. I just wanted to come back very briefly to this issue on contracts, because the Supplier Relief Fund was mentioned in there, which underlines how we're doing our best to support the providers and the people who work for the providers. And I note that you said that some of the money has not actually got through to the workers, but in any case, the providers are being provided with extra support, and that's good. But this also maybe offers us an opportunity to have a look at the contract that the providers have. And I've mentioned how we need to ensure they're treating their staff well in terms of sick pay, but in terms of domiciliary care, of course, this isn't the first time I've mentioned this. We need to ensure that those people who are peripatetic, who are going from home to home, actually have enough time to get between the homes as well. So, and I would have hoped that when it comes to contract renewal and review, that we are in some way ensuring that if we're paying these people out of the public funds, then they are treating their staff properly in terms of sick leave and time to do their job. So I'm just looking to you, Margaret, to see once again whether we're doing all that we can, and is there anything more that we could do to ensure that those contracts are being reviewed and are being monitored and managed. And that's it, really.
Thanks, Ian. Yeah, I mean, we are on a regular basis, we review our contractual arrangements, and we've always tried to write them in such a way that, for instance, we've got access to their books, so we've got an open accounting agreement with them, so we can have a look at what they're actually spending their money on, should we need to. And we also check their income tax returns every year to see what they're declaring as the pay rates for their staff. But we've never been able to get a legal situation where we can enforce a particular pay rate percentage. It's like any other business, you know, as simple as retail. You buy something at one price, you can sell it for whatever price you think you can get it for, and that's a difficult area. I mean, there is the new National Workforce Task Group that David Pearson, who was the DAS in Nottinghamshire until he retired about 2 years ago, that he's leading. And we were optimistic at first that that would give us some really good resolution to the social care workforce. But unfortunately, it's been set up as a short task and finish group rather than a long-term strategic group. But we do continue to encourage people to be as open as possible. And many of them, obviously, the smaller businesses actually are often better quality, as you know, than some of the bigger ones. I mean, just to go back to you, thanks for the workforce and all they've done. It's been quite interesting for me because I'm in lockdown in Wales, and until yesterday we had a 5-mile restriction on where we could go, which was a 1-mile restriction 3 weeks earlier. And so it's been much more severe. But interestingly, I've been in regular touch with the contact with the DAS down here. They've not provided any services, no day services, no visits, no anything to anybody that was taking those. So people in residential and nursing care have had their services, and Dom Care has had some service. But I'm familiar with a little lady over the road from me who's 98. She's not had any contact now for 15 weeks. The services are just shut down completely. So I'm really pleased with how our staff have responded in Gloucestershire and the types of things that people have done. genuinely out of goodwill and for a sustained period of time, and no real sign of them flagging either, which is great.
It's great. Yes, good.
Steve Robinson. Stephen.
Thank you, Chair. Yeah, Margaret, you mentioned about homelessness, and it's great to read that some people appear to have come out of the cycle and have managed to pick up some work through being in hotels or whatever. Do you see in the short term with hotels perhaps seeing that they can now have visitors to the area, that this will be a problem in the oncoming future with lack of beds now because hotels will be opening up for their clients?
Probably Sarah should answer this because Kath Rees, who leads on this work, works for Sarah. The reason it's in my report is for the contribution that Health have made to it, but I'll hand over to Sarah.
Okay, thanks, Margaret. So there's quite a detailed section on our response to homelessness in my report further on the agenda, but I can cover that now if you want me to, Stephen.
Please, Sarah, yeah.
Okay, so in my report, it talks about our approach to homelessness. So our approach has always been driven from the 7 local authorities. The districts have the statutory responsibility for homelessness, but we obviously have a role in terms of tackling inequalities in health, and we are the commissioners of housing for people in vulnerable circumstances that used to be called supporting people. So Kath Rees, the lead commissioner, very quickly took on a leadership role to bring the system together, and I have to say, I think they've done truly amazing work. We have an emergency protocol anyway for severe weather, and we've got a strong history of working together. So we've brought in quite a lot of money from MHCLG for our Somewhere Safe to Stay hubs and our community navigators, and you might remember those reports I brought to the committee last year. So we've always been, I think, leading the way in terms of what MHCLG wanted in terms of policy and development. And what they did very quickly was they developed a COVID emergency accommodation protocol. And there was a very clear steer from central government to bring people in as quickly as possible. So we commissioned initially 2 hotels, one in Cheltenham, one in Gloucester, and that ended up being for 12 weeks. We then actually bought beds in the 3rd hotel, and districts also spot purchased individual rooms in other hotels to meet the demand. I think from memory, we've had 330, at the time of writing the report, we had 333 placements. Some people were placed more than once, because obviously we're dealing with a very vulnerable cohort. And some of the placements broke down. Some people were placed in different hotels. At one point, I think the highest number of rough sleepers we had were 19 people that had refused to come in. I think just to assure you, we have an assertive outreach team funded by an MHCLG pilot. We were successful this year in getting the second year's worth of money. So it's a group of staff who are very experienced in working with the homeless cohort, who are going out and really assertively trying to bring them in, trying to offer them these safe, clean rooms where they've got their own bathroom, and it's dry and it's warm and it's safe. And for some people, they just couldn't, it was just too much. We're working with a cohort that have got drug and alcohol problems, mental health problems, or a combination of both, and are very vulnerable. So we still have a number of people who are sleeping rough despite our best efforts. So moving on, we came to the end of the 12 weeks contract with the hotels, and then we recommissioned that for a further 6 weeks with districts. And clearly the aspiration then is to not let people go back onto the streets. There's a national aspiration for that, which I think I wholeheartedly support. And we're working hard with districts to find suitable longer-term accommodation. This is some mean feat, really, because we need hundreds of single dwellings that are suitable for these people to live in. We don't have them, and of course, each district we've had a waiting list for permanent accommodation. So I'm grateful to Mike Dawson, who's the Chief Executive of Tewkesbury Council, who also provided some leadership here from a district council perspective. And together, Kath, the district reps, and Mike have taken this agenda forward, liaising obviously with Kathy and Carol as our cabinet members on this. So we've housed, we think, around 30 people to date out of this cohort. So we think we had, in terms of people, we had 330 replacements, but around, I think, up to about 180 people at one point. We've housed up to around 30 at the time of writing the report, and more longer term accommodation, and work is ongoing to work with the individuals to understand their individual circumstances, because it could be they could be repatriated back home if home is in Gloucestershire. It could be that it's appropriate that we find them accommodation here. And we're working through how we might continue to use those hotels. But to answer Steve's original question, my understanding is that the 2 hotels we're currently commissioning are happy because we're block buying beds, in effect, we're guaranteeing income, and we're placing people there, we're giving them somewhere safe to live. And you'll see in the report we've also provided food, and we've also provided what we call a concierge facility, which is a combination of concierge and almost security at one point, because obviously we've got a wide range of individuals housed in one relatively small space. So it was necessary to put in some additional support to enable them to access information support environments, and also to make sure that everyone was safe. So I think hopefully that does answer your question.
Okay, thank you. Kathy or Carol, do you want to add to that, dealing with homeless people, particularly in the future? Kathy?
Yeah, hi there. Yeah, I mean, certainly from what even's just been on the local, on the national news over the last couple of days, a number of people have actually found where they've been living in accommodation, they've managed to sort their lives out a bit. And it was quite hopeful on the news articles, seeing these people who had drug and alcohol problems were actually turning their lives around. So I'm very hopeful that a lot of the people that we've been helping will follow that path. As Sarah alluded to, there are that hard group of people, there's about less than 20, I think, but who just will not change. We try our best to help those people, but they just want to get back out on the streets all the time. But, we won't give up. We've got to keep trying. But I'm sure this pandemic, in a strange sort of way, has shown that homeless people can move on and have homes and be looked after. And I'm sure we're going to have some good out of it. So that's all I really want to say.
That's Kathy. Carol, anything to add?
Thank you, Stephen. Just to add that to support the notion of how good the staff are that we've got that are working across disciplines. One of the joys of actually becoming aware of the homeless situation and about recovery is that individual solutions are being looked at for individual people. So instead of using the term homeless, we've got a person who is without a home, and that person is being assessed individually, supported individually across disciplines, and enabled to actually stay off the streets. So what the creative solutions hopefully will allow us to have individuals in long-term accommodation if that's where they need to be. But we need to refresh our creativity. We need to reconsider what options we've got, and we must work with the district councils because they ultimately have to place people. So I think one of the observations I would make is that we've worked really hard, that the case studies coming forward are sad and make you cry, but also are joyous in terms of some of the resolve. So I think we're moving on, but from the perspective of the pandemic, this has been an opportunity to work with a really difficult group of people with good effect, I think. Thank you.
Thank you. Thank you.
Stephen, we've got Jeremy.
We've finished your bit for now, haven't we? Jeremy?
Thanks, Stephen. It was just some comments from what I heard is, with regard to the people that are being housed in our hotels, quite a large number of them, the majority of them, were in actual fact sofa surfing rather than being rough sleepers on the streets of Gloucester or Cheltenham or anywhere else. So providing them and getting them moved on into a permanent accommodation might be easier than those that were rough sleepers and who have mental health problems and addiction problems and other problems and live a chaotic lifestyle. We also mentioned about that we're using these hotels and that they were happy to take them on board. Well, of course, they are at the moment because people aren't travelling around and using hotels. But there will come a point when the hotels in question will want to take in normal clients. And we're going to need to find facilities in our bigger towns where we can house people temporarily, that we get them into permanent accommodation when they are genuinely homeless. And we need to start looking for that accommodation and make sure that it's all located in one spot, but it's located around the county, so that we can tackle the problems of people that really are living off the streets and need to be brought into temporary accommodation while we try and help them through into a permanent place to stay and live. So hotels are a temporary option because of the COVID-19 lockdown and because they're not doing their normal business. But it's not going to last forever. And I hope we're working up plans to make sure that we can deal with those people that are really sleeping rough, and also dealing with those people that are sofa surfing and need somewhere permanent to stay.
So,
any other questions?
For me to respond to that, Chair. So I agree, Jeremy. Yes, the hotels are a temporary measure, but we don't have the volume of suitable accommodation to move people into. So I think the hotels, my understanding is they're happy at the moment, because we are paying them for the accommodation, obviously. And we are seeing a decrease. We've now decommissioned one hotel, and our existing arrangements only go up to the end of this month anyway. So we're looking to see work with districts in terms of what else we could use. I think that the work the team have been doing for the past 6 weeks has been quite intensive in terms of understanding the individual circumstances of all of these people and risk assessing. Where could they go? Could they go and stay with family? And you're absolutely right. Some were sofa surfing, some were homes because of a relationship breakdown, because of the intensity of the lockdown measures. Some were genuinely rough sleeping. So they ended up in the hotels for a wide variety of reasons. That's why it's important we understand everyone's individual circumstances, what are their options, and actually then what do we need to do and step in at the statutory services. I think it's also important to say that our existing homeless services have not gone away. So we have really good rough sleeper services. They're still there, they're still working hard. And as Catherine said, we've got these 19 individuals, and we'll continue to work with them to make sure that they're as safe as we can make them on the streets, because no one wants to sleep on the streets. So, and these individuals are often very complex. So what services do we need to bring in from mental health, from drug and alcohol, from revenue benefits, from a whole range of different organisations to best support them to get off the streets? That work hasn't stopped. I think we've very much moved from our initial response phase in March and April into probably into recovery in May, actually, in terms of what's our longer term plan, with a very clear aspiration that no one will go back to the streets.
Thank you. Do you want to add any comments to that, Tim?
Let me just bring Tim in, see if he's there.
Just unmuted. I found the button.
Yeah, that's good, Tim. Go.
No, I just comment. I think terrific work's been done across the whole council family, actually, on this homelessness issue, and I really think it's a golden opportunity. Very aware at the national level, Dame Louise Casey has been engaged in the process, and obviously we know that there was an announcement, I think, of another 105 million at national level on top of what had been done before. But the test of this, I think, will be in a year or two's time to look back and see whether we were successful in transitioning people into some kind of appropriate housing. And I think they will continue to need support. I think the other thing is we can't just sort of leave people on their own, because they are very much in need of help and support. If there can be good things coming out of the pandemic, I hope this might be one of them.
Thank you. Thank you.
Andrew, you've got your hand up.
Yeah, I have. So, like Wayne's report, the report on homelessness is a really, really good, cracking news story. And one of the most uplifting pieces I've seen on television during the whole pandemic was when, I think it was the BBC, went into a hotel somewhere in the Midlands, and they were talking to some of these people who had been taken from the streets and put in a hotel. And their stories were actually really pretty moving. And they were saying, for the first time, I've got the security of my own bathroom, my own shower, my own toilet, my own bed, and nobody's banging on the door trying to evict me or move me on or turf me out onto the streets. And the stories that those men and women told were really, as I say, quite heartwarming, and a testament to the work that's been done across lots of local authorities in the country, not least from what I've heard from colleagues on the City Council. here in Gloucester and Gloucestershire with work between the districts and the county council. So I have some sympathy with the point that Councillor Hilton was making. We shouldn't be complacent. I suspect that next year people will take the attitude, well, okay, we've done 2020, pandemic is mainly behind us, we're going to start booking our getaway breaks and all the rest of it. And Gloucester, don't forget, Gloucester itself, like Cheltenham, are popular weekend breaks, locations, venues for people, not just in this country, but across Europe, and indeed in the case of both of our cities and towns across the world. People come to Gloucester and Cheltenham. And Gloucester, you don't need me to tell you, for the music festivals and the rugby, and Cheltenham for all of their fantastic festivals. So I suspect that next year will be more difficult in terms of hotel accommodation. Finally, just want to pick up a point that Carol made when she was saying that when it comes to housing, we're working with the districts here in Gloucestershire. And as a cabinet member who covers housing in my portfolio at Gloucester City Council, please do not underestimate the work that we're doing here in Gloucester City to find places, to find accommodation. It's almost a full-time job for me, talking to Homes England, all kinds of people, to ensure that we have the accommodation. And if you guys and the county council get any spare resources that you're not quite sure what to do with, please remember us in Gloucester, particularly the work that we're doing in housing. Thank you.
Thank you. Who's going to be next?
We've got Steve. You've got your hand up, Steve Robinson.
To come back and thank the officers and the cabinet members for their comments, and just what Carol was saying about individuals, and I'm pleased to see about the complex case cell, because there are those individuals that really need that head-on help. And I know just what was said about Gloucester City and in Stroud District, we are really trying hard to find that building that is going to be suitable. It's taking some time, but we are on the case on that one. But thank you very much for all your comments.
Thanks, Steve. Thank you.
You lower your hand, Steve. Is that all right? Jeremy, your hand's still up. Jeremy there?
Yes, he's looking for.
Dropped it. He's dropped it. That's fine.
I dropped it. Sorry.
Yeah, that's okay. No one else indicating.
Brian, you signalling? No. Okay.
That's it, Stephen. I think.
Okay. Thank you very much. Who's going to be next? Sarah. Hello.
So I was just unmuting and flipping between screens. Apologies. Okay. So in the report we've given you this time, so it's a report for information, but we've covered a number of areas. We've already covered housing and homelessness. We've had a huge number of questions around what we're doing now around the outbreak, and questions about data and availability of data, contact tracing, the national test and trace system. So you've got quite a long explanation in the report in terms of what the national test and trace system does, how it works. We've had a lot of questions around whether we should have a local test and trace system. So if I just talk you through some of the highlights. So it talks about the test and trace system and how that works. If you have a test, where your result goes and how that feeds into the contact tracing system. We then talk about the local outbreak management plan. So in the middle of May, towards the end of May, Department of Health and Social Care asked all directors of public health to publish a local outbreak management plan by the 30th of June. This is quite a big task. It was completed. We published our plan last Tuesday. And I think a couple of things to note about that. We've worked in partnership with PHE and the districts to manage outbreaks of communicable disease for as long as I can remember. And whilst we didn't have a dedicated plan for COVID, we did have a communicable disease outbreak plan that we had used for things like measles, Legionnaire's disease. We have outbreaks of communicable disease, we have cases of communicable disease fairly frequently. So I think the LOMP, as we affectionately call it in the Southwest, the Local Outbreak Management Plan, is really building on an existing plan, but focusing very much on COVID. So whilst the rest of the system appears to be going forward into some sort of recovery or reset, my team are very much, I think, developing a new business as usual, which will continue to be a response. So the ask of Directors of Public Health was to write a plan that will guide our local response to preventing cases of COVID, containing it. So if you do have symptoms, can you get a test easily? Have we made participating in contact tracing as easy as possible? Are we encouraging people to do it? Responding to outbreaks, so working collectively as a system to respond to outbreaks to contain any spread, and to use data and intelligence to monitor how COVID is moving through our populations, but also to inform how we do the prevention, the containment, and the response. So that's in essence what the plan does. I think it's important also to mention that up until now, our multi-agency response has been led by the Local Resilience Forum Strategic Coordinating Group, and I chaired that for 4 months, and I handed that over to the police last Tuesday. And now what we're doing is we're standing back the SCG, Strategic Coordinating Group. We now only meet monthly, and the main response will be delivered via the Local Outbreak Management Plan and a board called the Health Protection Board that I will chair. In addition to that, nationally, it was mandated we had a health protection board to lead the response, but also that we have an engagement board, and Mark Hawthorne is chairing this, and we had our first meeting yesterday. And the idea being that it's not a scrutiny function, it's not a decision-making board, but it's an engagement board for us to reach out to elected members, so it's cross-party, district and county members, but also representatives of different sectors where we expect, or the science tells us, we will see cases. So, for example, the Local Enterprise Partnership were represented, Gloucestershire Care Providers Association were represented. We've invited, but they couldn't make it, Young Gloucestershire, because we recognise that young people might well need slightly different messages, nuanced messages. The voluntary community sector, we invited the Alliance, we invited Health Watch, we invited Gloucester Association of Parish and Town Councils, to have a wide range of individuals who could speak either on behalf of different sectors or the communities they represent. Oh, and the Police and Crime Commissioner, how could I have forgotten? Apologies. So we had our first meeting yesterday. I think it went reasonably well. I think the learning from Leicester and the outbreak in Leicester is starting to come out. And some of that learning is, for example, that the soft intelligence you can gather from communities in terms of how people perceive the risk associated with COVID, how acceptable they find the testing, how acceptable they find the advice about social distancing is so valuable in terms of how you manage an outbreak. The data is getting better, the granularity around the data is getting better, but we really must have that soft intelligence. So I think we've probably got pretty much the right people around that engagement board in terms of how we manage things. And the small example I gave to the board in terms of just some recent learning came from Councillor Paul Hodgkinson. So we've been, as you know, we have a mobile testing unit that's moving around the county in addition to the big testing centre in Hampstead Meadows in Gloucester. And it went to Morton on Marsh. It was sited in a car park, and there were two individuals whose back garden backed onto the car park, and they were really, really concerned that people with COVID, which would be going to get tested if they had symptoms, would be bringing COVID to their back garden. It would increase the risk of them getting it. And I think that's a very legitimate thing to raise. It never occurred to me that people might be worried about that. But Paul was out that corner, had a phone call about it. He'd actually given them absolutely the right information and the right reassurance that I would have given, even though I could have given them myself. But that really helped us nuance the messaging and the information we give out around moving the mobile testing centre, because people are worried about that. We can allay their fears really quickly. So that's just one very small example, I think, of the role of the engagement board. And we've now got a much better process in terms of who we tell when the mobile testing unit is moving around the county. So, for example, it should be the county council elected member, the MP, the district council leader, chief exec, the district council member, and also we would then put some letters through the neighbouring properties' doors just to let them know what was going on, what to expect, and that very, very little risk to their health and well-being. But that was really helpful. And I think what I'm hoping is the Royal Board will begin to get some more of that feedback in terms of how our communications are landing and our engagement work. So the local outbreak management plan is a huge amount of work to deliver, and it's taking up a large amount of my team's resource. So I think going forward, it will become our business as usual. And some of the work we were doing pre-COVID will have to be parked, because we have to make sure that we are preventing and containing the spread of COVID. That's our absolute number one priority. So I'll pause there in case you want to ask me any questions about the LOMP, the Local Outbreak Management Plan, and then I'll move on to the data.
Any questions about the month?
Month.
Nobody putting their hand up, Stephen, on the system at the moment.
Okay.
Okay.
You can carry on then, Sarah.
I'll switch my screen just so I can see the up-to-date data. So,
Sure.
when we had to submit our reports, we put in there a document that we produce frequently for key stakeholders. So what you'll have is an update on the data as of the end of last Thursday, or maybe week before last Thursday. So it's slightly out of date now, but the pattern hasn't really changed. So what you'll see is in one of the diagrams, a curve, a pandemic curve as we call it. We clearly hit a peak around mid-April, and we are coming back down the other side of that peak now. And we see very low numbers in the county. And what happened last week, there was quite a bit of press coverage around the publication of what we call Pillar 2 data. So up until now, on the news, nationally, on the gov.uk website, if you looked at the number of cases and the number of tests done, that only came from what we call Pillar 1. So the NHS testing, either through hospitals or through PHE or through the drive-through in Brockworth, that was the only publicly available testing data. And since the end of April, early May, we've had something called Pillar 2, which are the mobile testing units that are placed around the county, and more recently, the permanent regional testing centre in Hempstead Meadows. Now, I've always had access to the data in terms of the number of tests carried out, number of positive tests, but I wasn't able to release it because the government weren't releasing it. I can't tell you why, I don't know, but it's really helpful now that the data includes Pillar 1 and Pillar 2 data. And what that means is that we've got a true picture of the number of tests carried out in Gloucestershire and the number of positive tests. And that gives us a degree of reassurance. So I think what I'd like to say to the committee is that every day, 7 days a week, we review this data alongside other data sets. So we're looking for any changes, any patterns in the numbers of positive cases. We get alerts every day from PHE if there are suspected cases in places like schools, and in the homeless accommodation, care homes, so we can be alert to the fact that we might be looking at a possible cluster or outbreak. So in terms of just some of the summary data, up until the 3rd of January, we had completed a total of 27,684 tests for Gloucestershire. That's as testing began. And in the 7 days prior to the 3rd, in total, we have conducted 2,904 tests. And of those, only 10 were positive. Out of nearly 3,000 tests, that's like 0.3%, and 1% of them were void. So that would mean that they didn't collect enough sample, or they were spoiled in transit, which again is not too dissimilar to regional and national figures for void tests. So we're still seeing very low numbers of cases in our community. Sometimes we see 2 or 3 a day, which is really reassuring, and I think is testament to the way that we've abided by social distancing, but I think there's an issue potentially about complacency. So obviously we've had a degree of the lockdown lifted recently, so we're constantly monitoring the data to see if we see any changes. And I think one of the things that's come out in the press about Leicestershire is that the Director of Public Health didn't have access to the data at a more granular level to be able to do that. And I don't know the details of what happened in Leicester. I know some of the issues. But I suppose just to reassure you that we have always worked on closely with Public Health England, with the South West Health Protection Team. And I think we've got good access to data. We have an alert system every day that tells me how many cases, positive cases have been confirmed the day before, and how many in 5 days before. And where there's any change in pattern that we haven't picked up ourselves, and PHE contact us and we look into it. So we've got, I think, a reasonably robust early alert system. We've got access to postcode level data around cases. So before I was getting a total number of cases, but I didn't know where the positive cases, I didn't know where they were. Now I'm getting their postcode, their date of birth, whether they were tested in Pillar 1 or 2. I'm getting, I should be getting their ethnicity, but that data isn't always complete, and their occupation. So we can tell whether they work in a high risk environment like a hospital or a care home or a school, where the scope for transmission is much higher. And there's another data set that's due to come out next week as well, which will give us much more detailed data. So I think it is beginning to come through, so we'll be able to have a much better oversight of the cases and be able to spot patterns as they happen. Again, I'll pause there. Happy to speak on the question.
Do we have any questions, members?
Just looking, Stephen. No.
Ian's waving his.
Yeah, Ian and Andrew.
Hi, it's just a quick question, Sarah, on what you were just saying about how you are analysing local outbreaks in various directions. You didn't mention ethnic minority there. Are we also analysing this by ethnic minorities to see if there are any patterns there, particularly in our major urban centres?
So in the last set of data, I said we did that ethnicity is a field in that data set, but it's not often complete. So we're reliant on those on people filling that in when they request a test, and we're reliant on the contact tracers completing that information. So where we can, we absolutely will be looking at this by ethnicity as well, because we know that there is a strong impact on those on BAME groups in terms of the outcomes from COVID. So we will be, if we've got the data, but it's dependent on us actually having that data field complete.
So do you have any comments on whether you are seeing patterns? And I'm thinking not only at BAME. I know in Cheltenham, for example, we have quite large relative concentrations of people from Eastern Europe, just for example. I don't know whether there's any pattern to them at all. So is there anything that you can make out of these figures or not at this stage?
No, we got our first data release on Friday last week, and we got the weekly one yesterday. As I said, the ethnicity field in the data in the spreadsheet is not well filled in, so lots of the data entries are missing, so we can't make any assumptions. I've not seen anything that suggests that people from Eastern Europe are any more susceptible to COVID than white British people. The evidence from PHE is around Black and minority ethnic communities rather than Eastern European. I think the other issue that linking to, I suppose, for Eastern European workers has been around the types of work they might do and the living accommodation. So there have been, you might have seen in the news, some outbreaks associated with meat processing plants. And we tend to find, in fact, places like meat processing plants or more agricultural places, that you tend to get migrant workers, which can sometimes be from Eastern Europe. And there's a piece of work that we're doing to understand where these particular factories are. This is part of our prevention work stream, because not only are you working perhaps, for example, in a meat processing factory quite close to one another, they're noisy, so you might be shouting, so the aerosols from your mouth will travel further because you're shouting, you're raising your voice. And also people tend to live together. There's a lot of mixed accommodation or houses of multiple occupation. And that was some of the learning that came out of the Western outbreak, in that the hospital had very clearly segregated its medical clinical staff between the COVID and non-COVID area. And then the staff were going home and living in shared accommodation, but obviously you had staff from the COVID and the non-COVID area in the same household, which of course caused transmission. So there's some work to do around that, but nothing specifically in terms of the high risk nature of being from Eastern Europe or anywhere else really, apart from the main communities.
Thank you, Sarah. Who's going to be next?
I think it was Andrew.
Andrew, yes, Andrew, sorry.
Yeah, hi Sarah, just a quick question. Can you remind us where we can access the data by postcode, please?
That's not publicly available, and because of the issue of people being identifiable. What you can do though is access on the gov.uk website every day. There's a spreadsheet you can download in total numbers of cases. What we're doing at the moment, and so obviously we've produced this report for you today, there's a limit to how much we can put into the public domain. The Office of National Statistics has published data on a map at a level of a medium super output area, which is a size of a geography that's bigger than a ward or a division, but smaller than a district. So now we're just beginning to bring a new team together to deliver the local outbreak management plan. We've got a bit of extra capacity coming in, and we'll be producing a dashboard that will come to Scrutiny, Health and Wellbeing Board, that sort of thing. So you'll be able to see with some degree of granularity where these outbreaks and cases are happening. So I'm proposing we'll be showing you maps, for example, at medium super output areas, so you can see where the cases have been, for example, in the last 7 days. But that's work in progress at the moment.
Okay, that was, if I can come back, there was a lot of information there, Sarah. So when you said it's not by postcode and it's in between postcode, I think you said postcode and district area. Can you just define that a little bit more precisely, please? Because that would help us to pick up these sort of issues that Ian was raising about concentrations in particular ethnic groups. And also it would give me this satisfaction of knowing if my area, because I've read it in different places, is really one of the least affected in the whole of Gloucestershire. I've read that on newspaper reports, but I've never seen any data which says your area, Andrew, is one of the least affected in Gloucestershire.
We're not able to share postcode data publicly. That was the first thing I said. So I think because
Why is that?
Because cases can identify people, so it's identifiable. So if we're five or more cases in a postcode, that would be fine. But at the moment, when we have 1, 2, or 3 cases each day, it's quite difficult to release that. So what we are thinking of doing, and we're testing this out at the moment. So data is available at a number of different levels. So we've been releasing data at postcode level, at district council level for a while in the members briefing. But we recognise that's quite a large geography and we want to have it at a lower level. So there are 2 other levels where the data is routinely available. One's called a lower super output area, which is the same really as almost as a postcode geography or a ward, which again is too local. And the Office of National Statistics have used something that's a bit bigger called a medium super output area, which is bigger than a ward or a division, but smaller than a district. And that seems to have been judged to have been okay to put into the public domain. So that's what we're planning on. So we can looking at how we might develop maps or dashboards that give you that information. They won't map neatly into your division because that means we're going to too low a level. But we're hoping to give people a degree of reassurance in terms of understanding where the cases are. And I suppose to reassure you as well that my team and I are looking at the data every day. So if there were to be an issue in a particular ward, we would be contacting the local member because quite frankly, we need your input, we need your local knowledge, we need to understand how best to communicate with your residents. And the fact you haven't heard from us indicates that there isn't an issue. We're having very, very low numbers of cases.
Okay, just if I can come back on that very quickly, Chair, very, very quickly. So that's reassuring that none of us as elected members have been contacted by Sarah or your team because of serious issues in our division. That's very reassuring. Going back to the postcode issue, if you took the first 3 numbers and letters, that's a pretty wide area. And for me, that would be good enough. So I don't understand why there's a sensitivity around showing, for example, my area is GL4, that's quite a huge area. The number, Sarah, for just the first 3 digits of any postcode. I understand if you go into hole 6, that's just 20 people in my road, and that then is easily identifiable. But if you went just to GL4, that would give you an indication. And finally, sorry, when you come up with this this information, you said you'll share it with Scrutiny and Health and Wellbeing. What about those of us who are members, but not on either of those groups? How will we access that, please?
So, I think you'll find that the GL4, I'd have to check that the GL4 type area is probably similar to a medium super output area. So what we've got to do is try to have some consistency with what is produced nationally and what's produced locally, because we got caught out massively. The media have been looking at some of the nationally available data and drawing some interesting conclusions, which we spent quite a lot last week trying to address.
Yeah, sure.
That was inaccurate, but it was a very logical conclusion they were drawing. So we don't want to invent something completely different. But then you can't compare Gloucestershire with Herefordshire, for example, or Warwickshire. That's not helpful. In terms of where we'll share the data, I think we're working on a cascade framework at the moment. I think there's a need to share the data far and wide. So, for example, of the district council members on the engagement board, we'll be sharing with them the dashboard they can take to their own district councils, their own district level scrutiny, Obviously, the Scrutiny Committee, hospitals will want to see it, Health and Wellbeing Board, and the ICA Integrated Care Systems Board. I know that the corporate leadership team will want to see it here at the council. I know that the cabinet wants to see it. So there's a whole range of places it will go to. And actually, if it's going to all those public bodies, there's no reason why it couldn't just go on our website, because if it's going to public meetings anyway, it doesn't have to explain. But I think there's something about putting it out into the public and without an explanation, and then bringing it to meetings and explaining it and having the opportunity to scrutinise it.
We're getting a lot of
spend our whole time taking it everywhere, but we'll have the opportunity to scrutinise it. Andrew's on mute.
Sorry, that's really helpful, Sarah. Thank you very much indeed. Thank you.
Simon?
Yeah, I'm going to disappear. Laura will mute everyone in a second. We've got Brian Robinson.
We're getting a lot of interference in the meantime.
I'm going to, can you hear me now?
The grinding has stopped.
Yeah, so Laura's muted everyone. I'm going to disappear now. So she's got the host. So the next person to speak is Brian Robinson.
Brian.
Thank you. My question goes back to the Sarah on the meat processing factories, because I think you were picking up that sometimes the risk there is actually in housing, that sometimes they're in very dense housing and may well be picking up the or sharing any infections in their accommodation rather than in the workplace. I just wondered whether anything had been done to look at whether the housing is actually meeting appropriate standards, because clearly if they are in accommodation which is overcrowded, we would be expecting the district council to be taking some action to try and make sure that the accommodation is of a certain acceptable level. Is any work being done either to understand if that is a problem or if it is to do something about it?
So the work we're doing around the local outbreak management plan is being conducted with the district council, so the local authority environmental health officers. We're in discussion about whether we can fund some additional resource for the EHOs to go and do preventative work with businesses. So there'll be some work to do around COVID, developing COVID-free workspaces, and our actions obviously people can take around distancing or shielding, that sort of thing. In terms of the accommodation, we haven't got that far yet as to whether there is an issue with overcrowding. We'd have to address that on a case-by-case basis. It is possible that's contributing to it, and we know that we've seen quite often in some cultures when you get a lot of intergenerational living and lots of people in living in one household, that also can lead to transmission. So there's something about looking differentiated between what cultural practices and what's inadequate housing stock, and I think the two are very different. So we'll be, I don't know whether that work is actually going to get to that or not at the moment. We're primarily focusing on the workplaces at the moment.
Thank you. The next question is from, who's next?
Brian, can you pick your hand down? That'd be great. I can't see anyone else's hands up.
Okay, can we have a 10-minute break now, please? Back at past.
Okay, yeah. If you just want to leave your microphones off, that's fine, and you can go off, but the recording will carry on. You can always turn your camera off if you want to.
Stephen, can I just say I've got somewhere else to get to. I just have to leave at past anyway.
Okay, thank you, Philip. Thank you for coming.
Stephen, I'm sorry. It's Sean Parsons here. I'm sorry I've been so late. I haven't had a connection this morning. It's only just come onto line.
Okay, Sean, thank you for telling us. Thank you. We'll start at past.
Can anybody hear me?
Yes, we can hear you. Yeah.
Oh, sorry, I don't want to make an announcement to the whole committee, but I do have to clear off about 12:20. I apologise for that.
It's now quarter past, isn't it?
Yeah, I thought we might have been over by then, Chair. So I apologise for having to leave early.
Have we got to come? 1, 2, 3, 4, 5. Another 6 people to come. 7 people, maybe. You
So I
can't
do
be excused if you have to go, Andrew.
Yeah, I do apologise, Chair. Okay.
Okay, thank you.
Thank you. Thanks for your patience.
Have we got any people to start with, Laura?
Sorry, pardon, Stephen?
Have we sufficient people to start with?
Yeah, so we need at least 3 members. So we've got Terry and Sean and Steve. So
Okay, it's 12:15. Let's roll. Have we finished questions to Sarah?
yeah, no one had their hands up.
Okay, so we can now move on to Wade.
Yeah.
Thank you very much, Chair. Can you hear me okay?
Yes, fine and dandy.
Getting nods. Good stuff. I'll keep it brief as possible because you've got the paper. Key highlights that I draw your attention to, and the fact that the agenda and the forward plan wanted an update on improvement board, which is included in the paper, but I'll expand on that slightly. I suppose just to let members know on HMI CFRS inspection update at the start of the paper. We were due to be re-inspected probably by, well, in fact, last month it would have been. Obviously, the whole re-inspection programme by HMI CFRS was paused. They are now currently working up what they call virtual inspections. So we will be inspected at some point in the autumn on our follow-up inspection following last year's cycle. We're due to have a full re-inspection next June. That will definitely slip. We don't know until when. Originally, we were told it would slip into 2022, but obviously HMI CFRS are now working up how they can catch up with all their inspection programme, which includes police forces as well as fire and rescue services. So that's the update on HMI, and we are well connected to our service liaison lead. Moving on to improvement board, I'm really pleased with the progress here and really pleased to be able to report this to Scrutiny Committee. You'll be aware from the report that there are over 120 findings that require action from the series of audit reports that took place last year. As a result, we established the improvement board. The improvement board didn't really get into full stride until this calendar year, although it started prior to Christmas last year. It took some work just to get the format right. So effectively, within 6 months of working properly, we've now approved and sent forward to audit 42% of the findings that were reported to us. So I'm really pleased with that progress. The improvement board is working well, good cross-section of staff. We have the HMIC have attended that board as well, so they've observed the board. We've had the local government association in to give us some objective feedback on progress, and as a result of that, we're making some tweaks and improvements to the way that board operates. Fair to say that there are bottlenecks in some places. So what we've identified, working through some of the findings, is that there are some GCC-wide matters to be addressed. So, for example, policy updates or changes, and those things sometimes take a little longer. But again, I think what it shows, because we've made up that board of a cross-section of people from across the county council, including Councillor Norman, we've got some pretty good reach back to unblock some of those bottlenecks, and it is really pleasing to note that we're making such rapid progress. A separate process in that once improvement board has agreed that we can sign off finding as complete as far as we can, we pass it on to audit. So because we review each of those processes, audit now take a full and active part in the improvement board meeting. And that occurred at the for the first time at the last meeting 2 weeks ago. So as opposed to audit having to come back and re-interview people, they're actually directly asking action owners in the improvement board and challenging action owners to make sure that the evidence we provide from the improvement board will meet the requirements of audit, but at the same time they're maintaining a degree of separation and objectivity, so that anything that gets reported back to the Audit and Governance Committee is obviously compliant with audit guidelines and how they should operate. So again, really pleased that we've evolved the improvement board to include audit to help streamline the whole process. I'll skip through and take questions on the report, but I would draw members' attention to some of the recovery items. So looking at the fire estate, we are working with estates and making sure that obviously the 21 fire stations are included in corporate estate conversations around one public estate. There's a huge contribution that we can make, I think, there by ECC looking at the most efficient and effective ways we can use all of the buildings across the estate, including fire stations, to make sure that we can really provide as much public value as possible. And that includes opportunities for staff to work more in a more agile way, to engage with members of the community in a more local way, and to provide contact and engagement opportunities for communities, because often those fire stations are in rural areas where there aren't other council facilities, but we do need a location there. So that's something I'm really keen to progress. Moving then on to trading standards, you'll see there's an update there on trading standards, and you'll see the significant increase in requests for advice, for trade advice, as a result of COVID, but also because we have suspended charging for advice that would usually be chargeable to certain business communities in order to support the economic recovery. So trading standards still very active, working very much in a remote way where possible, and are looking very closely through the National Trading Standards Institute about any legislation changes that are being made as a result of COVID, and how we can begin to provide those services again in a more physical way, whilst also looking at the future implications that Brexit is going to place particularly on trading standards, which will be an area that will be impacted and will have to make some significant adaptations as a result of Brexit. So that work is ongoing. You'll see that coroner's services are now creating a small backlog, I would suggest, in terms of the more complex hearings where they have to be heard by jury or have members of the public and families of deceased attend coroner's court. Some of the coroner's hearings and inquests that can take place with limited or no attendees have been taking place for the last month or more, and we're now considering how we can start to carry out some inquests with attendees, but whilst maintaining social distancing and complying with the PHE guidance. And obviously that's a matter for the senior coroner who's considering those cases. But effectively, there's been limited impact with the provision of IT equipment for coroners' officers to be able to work remotely. Other than inquests, there's been limited impact on the business of the coronial service, and they've actually done a fantastic job in providing advice and support into the temporary house of rest and the body recovery process with their expert advice and knowledge on handling and storing of, infectious people and bodies, etc. So they've switched up and helped with that response to COVID as well. And then finally, the civil protection team. Obviously, they've been embroiled in the response to COVID and supporting the local resilience forum. And it's worthy of note that, their business as usual continues. They were still dealing with Tewkesbury area and wide area flooding when COVID occurred. So they were stretched extremely thinly. And since then have dealt with a couple of incidents as well. For example, those water outages that you can see referenced in the report. But again, if you think about shielding vulnerable and members of the public who can't get out, the continuity of a water supply was probably more critical than it normally is. So delivering that in those times, again, required some pretty rapid and effective response. And they're also supporting the wider county council in terms of the business continuity management as a result of COVID, but also through that recovery stage. And I'm pleased to say as well, in CPT, we've managed to increase the capacity in there by recruiting some more staff to support them through this period and through the development of the business continuity approach for the county council in the coming months. And I'm happy to take questions at that point, Chair.
Thank you, Wayne. Has anyone got any questions for Wayne?
Jeremy's got his hand up. And Steve Robinson.
Okay.
Hello. Wayne, I was looking at your part of your report dealing with the fire estate, and particularly mentioned that 21 stations that provide opportunities to deliver a range of community-focused services. I just wonder how that's changed with the need to make sure people are safe at using those in regard to infectious diseases. But two, have you had any further discussions that might be useful with the police and ambulance services about the joint use of our fire stations? Particularly I think of the Police and Crime Commission, who's mentioned it in the past. So I just wonder whether any progress has been made on considering a joint facility in certain places around the county.
Thank you, Jeremy. Councillor Hurst, I'll come straight back on that if you're okay with that.
Yes, thank you.
In terms of the use of facilities, clearly fire stations and community facilities were closed as a result of COVID to comply with guidelines around infection prevention control. And they remain closed at the moment, and the management of opening those facilities is through the recovery cell. So you'll know the reinstatement of services. Each directorate of the county council has got a register of reinstatement, and they are being managed by that recovery cell in terms of the timing and the resources and procedures that need to be put in place to make sure that they can be opened appropriately and with the right controls in place. So again, the fire estate has been fully supported by AMPS, who ahead of the opening of each site will make sure a risk assessment is carried out and updated, and the site is visited, and any signage and controls, physical controls that need to be put in place are put in place by AMPS as per the rest of the GCC estate, regardless of where it is. On the second point regarding work with the ambulance service and Gloucestershire Police, we have, at an officer level, we are re-establishing the collaboration board between the Gloucestershire Police and Gloucestershire County Council and the Fire and Rescue Service. Members will probably be aware now that the Policing and Security Minister wrote very recently to the PCC advising that no decision will be taken regarding the governance case ahead of the PCC elections in 2021. And should the PCC still wish to take over the governance of the Fire and Rescue Service, then a revised and updated business case will now be required. So whilst I've not yet spoken to the PCC or the Chief Constable specifically about that matter, I would imagine that now we need to look at the mandate for that election to see what the PCC's intentions are. And it's unlikely that we'll see any progress around the states in the meantime, although we are very clear about our wish to engage with any and the right partner, particularly including the police, through the One Public Estate programme. And I've made my intentions very clear to the relevant people in GCC around the states that they need to be factoring in the fire estate, both as part of one public estate, but also as part of our recovery arrangements for agile working for staff. And then in terms of ambulance, they have already conducted an estates review and are moving more towards a hub and spoke model. They're opening county-based and larger ambulance depots from which to operate. So they're already embedded in quite a number of our fire stations, and they're fully aware and are looking at where they want to increase the use of the fire estate by providing standby locations and bases for ambulance crews once they've moved from a central depot. And the relationship and the understanding there between the executive teams and both fire and ambulance is very clear and quite direct. So I'm quite confident that we can support South West Ambulance where they require it.
Can I just come back, Chair, on this one? Just thanks, Wayne, for your comments. It's interesting that the PCC potential takeover has been delayed until after the elections next year. And with a new business case, we're talking about possibly 3 to 4 years of discussion and negotiation and an argument over whether the Police and Crime Commissioner should run our fire and rescue service. Surely it would be advisory to him to drop it as part of his manifesto, so that we can get on with the work of working collaboratively with the fire service, the police service, and the ambulance service. And we can forget this nonsense of him wanting to take control of the governance of our fire and rescue service. Just a comment. You might not want to respond to that, but that's my view.
Okay, thank you. Who else wanted to have a question in the echo?
So Steve Robson, Stephen, I think you've got two devices on again, so I'm just going to get rid of the one, okay, because we're having a bit of an echo. But yeah, it's Steve Robinson, and I think Sean Parsons, do you also want to speak as well?
Thank you, Stephen. It's not a question; it's just a thank you for the Nailsworth service. We had an extreme flood in the town on the 17th of June, and the service was excellent. The response from the Nailsworth station, who came out with all their guys and really helped to the town. It was really noted as the work that they put in. And then later in the day, a large delivery of sandbags came in because we were concerned about further thunderstorms. And Matt Amy and a team of fire officers worked really hard distributing these sandbags. And thank you very much. Thank you, Wayne.
Thank you for that, Steve. Much appreciated. Do we have anyone, Laura?
So Sean Parsons.
Sean, top right-hand corner on my screen.
Thank you very much. I just wondered, Wayne, if you could thank you for everything which the fire service has been doing. They're hugely respected, I know, among residents, and I think we can never make that point more strongly. We make it all the time. What I'm interested in is, what is the programme for taking forward the road safety?
Thank you, Councillor Parsons. So Councillor Norman is working on looking at road safety. So the next step is to pull together a working group to identify some good practice from elsewhere around effective road safety partnerships. I'm also speaking with Colin Chick because you'll know that Colin Chick has the TravelWise team, the road safety team working across there. So we're having conversations about what we might do in terms of needing to organise ourselves to make sure we've got the right data, the right information and coordination. And we'll be engaging with the Office of the Police and Crime Commissioner as well to see where and how we need to best align with the safe and social driving strand within the Police and Crime Plan. So early days at the moment, and the next step is a working group in order to look at how we organise ourselves to take it forward.
And do we have any sort of plans on financing of it? Who finances? I'm thinking of the police secretary.
Not at this stage. That'll be part of the working group's work because, unfortunately, what makes this slightly difficult is the majority of the funding will come from things like the speed awareness courses and speed camera income. Now, clearly, the county council doesn't control that, so that will be probably an element for careful negotiation and making sure that we align with other plans and strategies for best effect, and so that we can access the appropriate funding.
Thank you.
Thank you. Do we have anyone else, Laura? I don't think we do we?
No, sorry, I can't see anyone else.
Okay, thank you. So on the agenda now, we move on to the
performance reports.
Performance reports.
Yeah.
Which, if we go through and just highlight the ones where there are major movements. First, come to adult social care performance. Do we have any areas of concern there? There seems to be a red triangle in the third box, total number of people in employment with a disability.
Yeah, so we've seen during COVID, both locally and nationally, a reduction in the number of places available to people with disabilities as there are more people looking for employment at the moment. So we're keeping a close eye on that. And I know Vicky Walters has been doing some liaison about it nationally, because the project that we're doing is about the people who are the furthest from the work environment, the least likely to get employment. And up until recently, we've been doing really well. But as I say, it's just the numbers have dropped a little bit. We're keeping an eye on that. We have got the next lot of European money.
It is getting better, isn't it?
It will get better.
Further down the page. What's the blue circle mean? Regarding hospital, delayed transfers from hospitals. A blue circle there. What's that mean? Does anyone know?
Yeah, so that's because during COVID, they've suspended that data collection nationally. We're not required to collect so that's a great result for us. I mean, we were doing really well in it anyway, but it's lovely not to have to argue about who's responsible for not moving somebody.
And then we come on to, Margaret, we come on to service users who have had a reassessment of their needs. That's gone down from what? 48.9 to 36.4 with the target of 80.
This is our most difficult measurement because of the way we work now with the 3-tier conversations and the very responsive service. New referrals will always take priority over reviews. However, we regularly undertake a desktop review. It's just we can't count it in that quota. But I know that whilst we've been in COVID, Dawn's had some of her staff focusing much more on reviews. And we always prioritise the reviews where either they've got complex needs and are likely to have quite a sophisticated package of care, or those people that are obviously brought to our attention because there are concerns about them. And the people that we leave to last are usually people in stable situations, particularly in long-term care. But it's the only bit of our performance really that suffers. But I don't think we're on our own.
It's been suffering, hasn't it, since March 19, when it was 70, and it's now down to 36.4.
Yeah, and everybody is entitled to a review. So, of course, anybody that asks for a review then gets up the priority list. But as we develop the new way of working post-COVID, I think we're going to have to think about another way of doing it. We did have a few years when we had a review team So a half a dozen staff just dedicated to doing reviews. But we found that didn't work because they got taken for safeguarding priorities all the time. And we're in danger of doing that again at the moment because our safeguarding referrals have gone up in COVID. But yeah, a thinking hat job, I think.
We are in unusual times, aren't we?
We are indeed.
When things are scattering all over the place. A lot of greens there, Margaret. Thank you very much. Now we are coming now on to Tim, Prevention, Wellbeing and Communities.
Would you like me to respond to this one, Stephen?
Yes, please, Sarah. Thank you.
Okay. So our scorecard's been shortened. So we were asked to take out some indicators. So there's far less to report on. So you'll see at the top, NHS health checks. Well, they were stopped during partly March because obviously primary care changed its delivery model in response to COVID. So we haven't got the data for that. Most of the performance is actually good. So you can see the green stars going down, particularly draw your attention halfway down the page. The percentage of pregnant smokers achieving a 4-week quit date. We're one of the top performing smoking cessation services in the country. So we achieved 90%. In December 19 against a target of 70%, so that's really, really good. As we move down the page, you'll see there's a blue circle. That means within tolerance, but I'm led to believe the data didn't arrive in time for the dashboard. So we have a number of mandated visits that our health visiting service must complete, and one of them is a new birth visit within the first 14 days. Now, for a number of logistical reasons, for some families, this is really difficult because you might not have been handed over to a midwife, your child might be very sadly in hospital, you might have decamped to your mother's, for example, in another part of the country, not be at home to receive a visit. So we're allowed to look at it within the scope of 30 days, and this was a way to understand of the 3 tiers of families that we look at. So the universal offer, those that might have slight vulnerability is called the universal partnership offer, and then our most vulnerable families are universal partnership plus offer. So looking at all the offers from the health visiting service, and our target is 100%. So in this quarter we got to 96.2% within 30 days, and I'm assuming there's not a comment there. I think it's probably because we've brought most of our team off their normal business and have not been responding to these sorts of requests. So the normal reason why we would not get 100% is for some of the reasons I've outlined. Maybe the child is in hospital, maybe the family weren't at home. But just to reassure the committee that certainly for the more vulnerable families, the health visiting service do go to great lengths to make contact with those individuals, and certainly focus their work on the more vulnerable families and the universal ones in terms of getting in touch to see the child and the mother. The indicator below, there's a red triangle, indicates that this is out of tolerance. So you'll see there it's 86.8%. And switch screens, bear with me, there's an explanation from my team. So all the children in this cohort have been offered appointments, but they've only reached 86.8% of them. They saw an increase in children that had their development review by 12 months, and that's increased in the Universal Partnership and Universal Partnership Plus levels. But they've had 5 families decline due to disability, which normally means that they're under the care of the clinical services anyway. The purpose of this visit is to do a developmental check. If you're already in regular contact with a paediatrician, you don't really need to have a development check by a health visitor, and 2 by parental choice. So the notes here say that if the appointment is not kept, every action is taken to make contact with the family to ensure they're assessed. This includes writing to the family, checking with the GP if they've been seen in surgery, if the address is correct, or the contact number has changed, as well as opportunistic visits are carried out to check just to see if they can make contact with the family. So that brings me to the end of my indicators. I'm happy to take a question.
Thank you, Sarah. Thank you. We now come on to Dave Normans. Lane, are you still with us?
Sorry, councillors, was that me? I'm here.
Yes. If we're going on to the performance charts now, Dave's not with us, but we've got a chart for your responsibilities, which does show us, I mean, we're not hiding this, are we? The number of safe and well visits have in fact decreased, haven't they?
Yes, and if you recall that we talked about, we'd actually suspended the safe and wells, and we were also focusing, prior to lockdown, we were focusing on reducing the backlog that had been identified, because there were some high risk vulnerable within the backlog number. So we are revising down. If you remember, the target was originally 10,000 per year, which was an arbitrary figure. We're revising down that number to a number that is more appropriate for the amount of referrals that come in, but also the capacity that we've got to actually respond to that number.
Yep.
But obviously making sure that we prioritise appropriately and we don't miss out any of the very high risk. So that number is impacted by an increasing backlog and COVID as we've moved through. But as I said earlier, we've put additional staff and community safety advisors into the cohort of staff who carry out that work. And we're also making sure that out of hours and on weekends, our operational firefighters are available to respond immediately to deal with high risk vulnerable referrals and then pass them on for more intensive support afterwards.
Okay, thank you. Have we stopped
Sorry, can you hear me?
the number of accidental dwelling fires? Hello?
Wayne, are you still there? No. Stephen, we've got some hands up anyway while Wayne hopefully.
Hello.
Oh, Wayne, are you back?
Who would like to ask Wayne a question?
Right, I'm back in if you can hear me.
Yes, we can, Wayne, loud and clear.
Super. So you got the fire performance update. I think you'll see there was a little bit more there in relation to accidental dwelling fires, which is within tolerance. And there's reference further down in terms of road safety that the number of killed and seriously injured people is on the increase if you look at the quarter to March 2020. And again, as I said, we'll be looking at that with the safe and social driving work that we undertake, but also the review of the County Council's approach to road safety. And obviously, the following quarter might demonstrate a similar pattern in relation to the type of accidents that we've been attending and the type of incidents in road safety being much lower frequency and volume, but the severity has remained the same or increased where they have occurred. Happy to take questions.
Okay, who have we got for questions, Laura?
So we've got Brian Robinson.
Brian.
Thank you. My question really relates to the road safety on page 8 of the report, or page 58 of the pack. And that's where the number of killed and seriously injured has gone up significantly in the first quarter. And I just wondered if there was any underlying reason that we understood for that and what we were doing about it.
In terms of the underlying reason, there are no particular trends that demonstrate of accident or issue. We're working on it through education means as well. So the Safe and Social Driving Partnership does include the Travelwise team from the County Council. It includes staff from the Fire and Rescue Service in terms of education, and obviously it includes the enforcement element through Gloucestershire Police. So what we do is look to the hotspots and target the hotspots, which we do normally, but unfortunately it's through lagging data. So where we start to see a spike, we'll position road safety teams and we'll carry out education in those areas. And that's generally the route that we use to try and tackle any specific spikes. But I think, again, that's part of the review around our whole approach to road safety as a county council, just to make sure it's as joined up as it can be, but also it's hopefully more proactive as opposed to reacting to some of the lagging indicators that we get.
Come back. We had quite a wet winter. Wasn't that icy? I don't think. But I just wondered whether that might have been a contributory factor. The weather conditions were poor for driving in that period.
We normally see a spike of activity in the winter quarters anyway. So obviously, when the darker nights, as the clocks go back, the nights get darker and the weather worsens, we see that increase in the quarters from October to January and January to March. So they are generally worse quarters for the volume of road traffic collisions and the severity of accidents.
Thank you.
Who's next, Laura?
I can't see anyone else's hands up. Brian, could you put yours down? That'd be great. Yeah, so I can't see anyone else indicating.
Okay, thank you. Thank you, Wayne. And now we come on to strategic risk, which we're happy with the strategic risk summary. Takes a bit of understanding, doesn't it? But there we are. Does anybody have any questions about the strategic risk summary?
No one's indicating.
No. Okay.
No.
Thank you. And then that brings us then on to the work plan. When's our next date? The 8th of September. We've already got the normal things, the performance reports, the director's reports, and then we also have an added report on COVID testing in care homes and amongst domiciliary care workers. Are there any other items which at this point in time we think that we want to cover on the 8th of September meeting? Are you going to offer us anything, Sarah and Margaret?
I can bring you the dashboard for COVID-19, which should be ready by then, so we can have a look at that and an update on what's happening in our communities from a COVID perspective.
That would be good, I think. Be interested in that, so we can put that on the list. Laura, please. Margaret?
Would you like an updated account of sorts of things that we've been doing, a bit like today's two reports?
Yes, please. Yeah.
Okay.
So I think that covers September, doesn't it? Really, it could be another long meeting. And then
Stephen, could I just? I know it will come under Margaret's or Sarah's reports, but if we could keep a check, I know we will do, on homelessness, with in September, with the onset of the winter.
Yeah, with the follow-on
where we are with that
accommodation.
Yeah. Thank you.
Okay. Rand?
Stephen, can I come in?
Yes,
I think it would be useful in November probably that we get a report back on the longer term viability of care homes, picking up on the trends that we've talked about. I think it's important we understand whether care homes are going to be changing significantly and what that might mean for adult care.
Yeah, happy to do that. It might be a bit early, but it might just be an early picture. But then by the time we get into the next financial year, we'll see the impact of COVID on them. But I'm happy to do that.
Okay, thank you.
We can look at that from an early doors point of view, can't we? Anybody else for November?
Oh, Ian's indicating.
Ian, you're mute.
Brian was
No, you're
saying
not.
there about the viability of care homes. I just wondered if we could include in that the domiciliary care providers as well.
Yes, Margaret's signifying that's not a problem.
Yeah, I'm happy to do that, Ian.
Thank you.
Some of it will be our perspective as opposed to sort of commercial information, because I doubt very much if they will give us that. But we'll see what we can get.
Thank you.
And then we're looking for items for January.
I mean, we don't have to necessarily plan for January right now if we don't want to, unless there's anything that would fit there. It's up to you.
Well, we've done September and November, haven't we? We'll see what goes on from then.
Yeah, because other things
Everyone
might sort of
happy
come
with
up in the meantime.
Is everyone happy with doing that? Few nods, yes. Okay. Okay, I think does that bring us to the end of today's meeting. Thank you all for your attendance and your interest and your questions. Sorry, Tim's waving like crazy. Tim.
I was just waving goodbye, Chairman.
All right. So...
No, I think it's been a really good meeting. I have to say, it's been a really good meeting, and I think that the report on the care homes and Sarah's report on homelessness, I think were very good, and I think
they will be valuable for the future, won't they?
They will. The huge work that's gone into it.
Yeah. Okay. Well, thank you very much for coming. Thanks again for your questions. Really a certain meeting. Thank you to Margaret, Sarah, and Wayne for giving us such sensible, well thought out answers. Thank you all very much indeed. Thank you.
See you soon.
Bye.
Where's Steve waving now? Steve? Brian's waving.
Thank you. Bye.
Brian?
Going.
Are you just getting off?
Yeah, they're going.
Okay, you're
See you
off.
next time.
Steve? On.
See you, Laura.
Bye.
Cheers, Terry.